All right, we're about to dive into one of the most intense, high-stakes fields in all of medicine, pediatric cardiac anesthesia. This is a world where doctors are doing life-saving surgery on hearts that are impossibly small and, as we're going to see, are completely different from an adult's. It's a specialty that's really all about mastering physiology under some of the most extreme conditions you can possibly imagine. So that's the big question, right? And the answer isn't just about making everything smaller. It's about managing a unique physiology that's changing by the second, where the margin for error is, well, it's pretty much zero. The real challenge is understanding the fundamental principles behind these tiny patients to get them safely through surgery. So let's break down how they do it. Okay, first things first, and this is absolutely crucial. A baby's heart is not just a miniature adult heart. It's a completely different machine. See, an adult heart can just pump harder if it needs to. That's called increasing stroke volume. But a newborn's heart can't really do that. It's stiffer, with fewer muscle fibers. So to get more blood out to the body, it has one main trick: beat faster. If that heart rate drops, cardiac output plummets. It is a much, much more fragile system. And believe me, the challenges do not stop there. A newborn's little body is already running at full tilt, just flooded with stress hormones. The system that moves calcium around to make the heart muscle contract, it's still under construction. And on top of all that, their entire lung circulation is in the middle of this massive switch from living in the womb to breathing air. You put all that together, and you have an incredibly delicate balancing act for the anesthesia team. Now, to do these incredibly complex repairs, surgeons need the heart to be perfectly still. That's where the heart-lung machine, or cardiopulmonary bypass, comes in. But for kids, this isn't like it is for adults. We're talking about exposing them to biological extremes. They're cooled way, way down, sometimes to just 18 degrees Celsius. And often their blood circulation has to be stopped completely for a period of time, something that's almost unheard of in adult surgery. But here's what's maybe the most mind-boggling challenge of all. The amount of fluid needed just to prime the bypass machine can be double a newborn's entire blood volume. 200%. For an adult, it might be a quarter of their volume. This huge dilution of their blood creates this massive inflammatory response and fluid overload that can cause real damage to the heart, the lungs, and especially the brain. So you have this massive fluid problem. What do? Well, you use this incredibly smart technique called Modified Ultrafiltration, or MUF. After the bypass is done, all of the patient's blood, plus all that extra fluid from the machine, gets passed through a special filter. It literally pulls out the excess water and all those inflammatory molecules, basically hitting the undo button on that massive dilution. And the results are just incredible. Muffy does way more than just get rid of water. It means less bleeding, the heart pumps better, the lungs work better, it even helps protect the brain and get more oxygen delivered everywhere. It's an absolutely key tool that helps these tiny patients bounce back from the enormous stress of being on the bypass machine. Okay, so besides fluid, there's another tricky problem: blood clotting. To prevent clots on the bypass machine, we use the drug heparin. But heparin needs a protein called antithrombin 3 to work, and newborns just don't have very much of it. This means all the standard tests we use to monitor clotting aren't nearly as reliable. It takes a much more careful, nuanced approach to keep them safe. Now, let's talk about the brain. This is a really critical and honestly a pretty sobering point. The challenge of protecting the brain starts before the operation even begins. We now know that a lot of these infants, because of their heart defect, already have some structural brain abnormalities before they even get to the operating room. They're starting out in a neurologically vulnerable state. And the worry isn't just about a big, obvious stroke. It's about the more subtle, long-term outcomes. Things like motor skill problems, speech delays, attention deficit disorders down the road. These are the kinds of things that can change a life, and the entire team works tirelessly to prevent them. The goal is never just to survive the surgery, it's to thrive for a lifetime. So, how do we protect that vulnerable brain? It's really a multi-pronged defense. First, we use special monitors that are constantly watching the oxygen levels in the brain. Second, for really complicated repairs, surgeons can actually perfuse the brain directly, sending blood right to it while working on the rest of the body. And third, we are absolutely obsessive about controlling blood sugar, because too high or too low can both cause injury. Okay, let's look at how all this applies to a real condition. We'll start with a classic one: tetralogy of Fallot. often known as blue baby syndrome. The key problem for anesthesia is that there's a big blockage preventing blood from easily getting from the heart to the lungs. This forces blue, deoxygenated blood to mix in with the body's circulation. Managing the anesthesia here is a genuine tightrope walk. You have to keep the blood pressure in the body, what we call systemic vascular resistance, nice and high. If it drops, it creates an easy escape route for all that blue blood to rush to the body, causing a dangerous drop in oxygen called a TET spell. So you're constantly balancing, keeping body resistance up and lung resistance down. Now for something completely different. A truly remarkable surgical innovation called the Fontan Procedure. This is for kids who are born with basically only one working ventricle. The surgery completely reroutes the plumbing so that all the blue blood coming back from the body flows straight to the lungs, completely bypassing the heart. And here's the critical part. You really gotta let this sink in. There is no ventricle, no pump, pushing blood to the lungs anymore. It's all passive flow. That means if anything increases the resistance to blood flow in the lungs, the whole system can just back up and come to a grinding halt. The #1 anesthetic goal is to keep those lung vessels as wide open and relaxed as possible. Of course, the anesthesiologist's job isn't just in the big operating room. They are absolutely essential in the cardiac cath lab too. This is where they manage kids for procedures like closing holes in the heart with little devices, blocking off bad blood vessels, or using balloons to open up valves that are too tight. And don't ever let the words less invasive fool you into thinking it's less dangerous. When you inflate a balloon inside a critical artery, you can completely stop blood flow. Pushing catheters across a tiny heart valve can cause it to leak massively. These procedures can cause just as much chaos as open heart surgery, and they demand the exact same minute-to-minute vigilance. And that really brings us back to the ultimate question at the heart of all this. In pediatric cardiac anesthesia, every single decision is a calculated trade-off. It's not just about getting the child through the surgery, it's about the incredible balance of healing a tiny heart today while fiercely protecting the potential of that developing mind for all of their tomorrows.